Hey, everybody. Welcome back to the Pre-Hospital Paradigm Podcast. I caught him off guard, which was fantastic. We're back with the usual crew. We got Dr. John Hill over there. And, of course, we've got Caleb Ferroni sitting to my left. I'm Scott Wildenheim. And Dr. Arielle Olicker is joining us again. Thank you so much.
Thanks for having me back.
Yeah, it was. We had so much stuff that we had packed into the list from last time. We're getting the leftovers, right? We have all of the stuff we didn't. We really focused on in your first episode there. We really focused on the resuscitation of the neonate. Mm-hmm. And there was a whole bunch of other stuff, basically. Early life, illnesses, and birth defects and stuff like that was on our list. And we went long on that last one, and we still had plenty of, it's like,
yeah, we meandered all over.
Yeah, all over the place, and we decided we just have you back, and we'll do it in another bit. So, yes, appreciate having you here. Thanks for coming back. This is fantastic.
Thanks for having me back.
And I don't think I said in this episode, but Dr. Olicker is our neonatologist attending a neonatologist at University Hospitals in Cleveland. So, one of ours, yeah. So the boy, we got a whole list of things here in no particular order and no real, I don't want to say order of importance, but in order of severity. But let's, I think the first thing on here is let's talk about the chronically opioid dependent kids, right? So what does this look like for, of course, on the EMS side of things, we're so accustomed to the both acute overdose, mm-hmm. mostly in our adult. We occasionally run across a kid, accidental ingestion or something to that effect. But let's talk about mom who gives birth to a chronically dependent kid now. What does that look like? How messy is that for you? And what does your treatment look like?
So babies on chronic or moms on chronic opioids have babies who have been chronically exposed to opioids. And as the pandemic has gone on, epidemic? I suppose it's probably a pandemic.
Yeah, you may as well call it. Yeah.
Anyway, moms who've been chronically taking opioid drugs have babies who are chronically exposed to opioids. And there's a whole variety of opioids, and there's some that are prescribed and some that are explicit. But all of them have similar effects. It's interesting. The effect on the neonate is not actually dose dependent.
Really?
So, yeah. Oh. So people on very high doses of opioids throughout their pregnancy don't necessarily have babies who are withdrawing more than people who have babies who are on, or moms who've been on lower doses or have had less exposure overall. It's more the length of exposure than it is the total dose. A great example of that, and we don't necessarily know why, but people with sickle cell disease who chronically take opioids for their sickle cell pain actually tend to have babies who are less symptomatic from opioid exposure than people who have been on opioids for other reasons, which is interesting. Mm-hmm.
That specific disease process.
Mm-hmm.
Huh, that is crazy.
Yeah. I don't know why that is, but it is interesting.
It is super interesting because, how often do we see, we often see sickle cell patients, let alone sickle cell moms. Is it I guess could it be from the it's not like they're chronically, they're taking for over a long time, but my sickle cellers that I see, it's more intermittent. Intermittent doses, use, yeah. As opposed to like steady state, chronic everyday use. Chronic steady state use, yeah. Yes, but I always see them in extremis, and EMS probably same way, right? Yeah. We don't get them when they're just a little bit bad. Correct. Yeah, we get them when they're a mess. Yeah.
Yeah, there are a good number who have some degree of pain all the time, who take some degree of opioid quite frequently.
What about is it medication specific, like oxycodone versus the one I'm really curious about is buprenorphine. There's a big push for buprenorphine from a management standpoint of these patients that have chronic opioid dependent use. Does withdrawal patients that's on a bup, do they have babies that withdraw too?
They do.
Okay.
The thing about different medications or different drugs is the difference it makes to the baby is in the amount of time it takes to see withdrawal. So shorter acting drugs, you'll see withdrawal faster than you will with longer acting drugs. So you'll see withdrawal fairly quickly within the first day or two when you're thinking of drugs like fentanyl. Mm-hmm. And as it gets to longer acting drugs, your methadones and buprenorphines and things of that nature, it can take a few days. We usually watch these babies up to 5 days, and if they don't show signs within 5 days, then we're pretty confident they're not going to show signs.
Yeah. Okay. Now, let's frame that up a little bit into a field delivery. What if we know mom is a chronic, let's say, illicit user, like we kind of framed this up initially, but then, I guess it doesn't matter. Mom has some sort of, chronic opioid exposure, whether it's prescribed or not. And we know this. I think there's going to be the wantonness for the provider to spritz the kid with Narcan. What kind of mess is that setting us up for in the field? Yeah.
So first of all, when a baby is born from a mother who's had chronic opioid use and their opioid use hasn't changed or hasn't gotten heavier or worse in the last little bit before delivery, those aren't babies who are going to be sedated when they come out.
Okay.
At least not from their opioid use.
Fair. There's something else going on.
Right. You can certainly have babies who are depressed for another reason, but it's not going to be the chronic opioid use that makes them have birth depression. If you have, for some reason, a mother who is not chronically opioid dependent or not been using opioids throughout their pregnancy, who gets a dose of opioids prior to delivery, those are babies who can be sedated on their way out. Yeah. It'll be probably hard for you to tell in the field if you have a baby who is sedated for chronic opioid use or a baby who is sedated or depressed for another reason. So for this baby with chronic opioid use, one of the worst things you can do is actually give Narcan.
Right.
The baby then has been making receptors to opioids the same way that adults make receptors to opioids over time. And if you give a baby Narcan, it can actually induce seizures in the baby, which is a different world of hurt.
That's why I kind of framed it up with what kind of mess are we getting into here.
Yeah.
It's
setting you up for seizures.
Seizures, yeah.
And the acute exposure?
I would say if you don't know what's happening, so if it's not opioids that we have given, so if you don't know what's happening, I wouldn't give a baby Narcan. If you have a baby in the field who is depressed for whatever reason, I would focus on your ABCs. So focus on your airway, focus on breathing, and we can worry about the rest later.
Yeah, absolutely.
BVM safe play, yeah.
Palmedine makes a really good pediatric BVM.
Oh, boy. He's got to get a cut in.
So I think in the system we had an incident a few years back maybe of a chronic patient that delivered and they ended up Narcanning the baby. Do you remember this at all?
I think I vaguely recall some structure of that, and it yielded exactly the outcome that you described. Right?
Yeah, but I think that it's so ingrained in the paramedics and the basics mind that opiate, you're going to give Narcan. So I think that's an awesome teaching point right now that we can't be blindsided by that.
Yeah. Now, let's say you have a baby in the field who you've given an opioid to. So I think we talked about last time, but we use opioids for sedation prior to intubation. So let's say we have a baby that you've given morphine to, and now you're having trouble getting an airway. That's a baby? Absolutely give Narcan.
Yeah.
Go ahead and give Narcan, go back to using that baby's intrinsic respiratory drive.
But you made a really good point off camera, though, about giving morphine, for example, is going to outlast your Narcan. So you have to be careful about that. I think that hopefully we're at the hospital at that point, but make sure the hospital knows that Narcan was given for a morphine exposure.
Expect the time to come off soon, right?
Yeah, or if you're even on a long trip and you've given Narcan and you're using the baby's intrinsic respiratory drive on something like CPAP and the baby starts to breathe more slowly, that could be a situation in which you want to give Narcan again.
Yeah, I mean, absolutely. We have departments that have 40-minute transport times.
Yeah.
That's the norm, right? So,
or they're making the correct decision to go to a center that doesn't have a NICU to a center that does have a NICU.
Correct.
And so they're going to have a longer than normal transport. They might go from 20 minutes to 40 minutes.
I think,
or certainly around here, weather is an issue, and your usually short trip can become a very long trip.
Indeed, it can.
Or you may not make it. I've been on an ambulance before where we slid off a driveway and we had to wait for a whole other ambulance to show up in a snowstorm, and we were there a while.
So anything else on the chronic on the neonates and the opioids? I think all that's very
just make sure that what you're giving is an opioid if you're considering Narcan. We
Well,
do have other things
you
like ketamine.
Every analgesic isn't. It used to be the case in the EMS world, right? As every analgesic we had was an opioid, so you could reverse it with. Well, you had the false sense of security that you could make everything better in a second with Narcan, and now we've got other agents that.
The only other thing I would say about it is there are labels in the drug boxes for a reason. If you draw something up and mix something, or draw something out of a vial into a regular syringe that is not labeled, make sure you label that so that you don't adversely give the wrong flush. So, Sharpie,
I think
paper.
this is required reading for every pre-hospital provider right there.
Sharpie, labels.
Sharpie, yeah. I carry very few things with me on the truck, but that's a not negotiable. I'm old and I can't see, so I carry my own light.
So you write really big.
I write really big. That's very defined. Everybody knows it was my report.
But you bring up an excellent point. So you were talking about opioids being easily reversible, and there are some things in your arsenal that are not going to be easily reversible. That's exactly the reason why we don't paralyze our babies, and I think we talked about that last time too, but we give opioids for sedation so that, number one, you don't have pain or discomfort during your intubation.
Procedure, yeah.
And the AAP recommends giving some analgesic. It doesn't specify which, but it recommends giving something for analgesia during all intubation attempts. So we handle that with our opioid, in our case with morphine. But we don't use a paralytic. We do it in the hospital, but we don't use it in the field, and we don't use it in the community hospitals. And the reason for that is these babies can be difficult airways, especially if you're not accustomed to small airways or baby airways. And so if you, for whatever reason, have trouble with your airway, you can easily reverse your morphine. It's really hard to reverse your paralytic.
Yeah, right. Yeah, absolutely. And I think any good EMT would sit there and tell you they're not comfortable with babies. We just don't get exposed to them enough.
Of course.
I mean, unless you're running a peds truck, I just don't. I'll never. I mean, I have kids, and they're young still, so I'm a little more comfortable than some other people, but not medically. I mean, if I have to intubate the child, I'm not going to be the one
that doesn't make you better at it.
So
I'm not comfortable with airways with teeth. You know what you know.
That's a good point.
Fair point. Now, you're talking specifically about morphine. You broaden that to an analgesic. In the field, it's almost going to be a ubiquitous answer of fentanyl. Is there any reason you guys choose morphine over the fentanyl, or what's the reasoning there?
So in the hospital, we use fentanyl. The reason we have, and this is a little bit controversial actually, so the reason that you're using fentanyl and the reason we use it in the hospital is that it's rapid on, rapid off. And we love it for that reason. But it does come with the risk of rigid chest. And while rare, it does happen. Most of the rigid chest we see is actually just from difficulties with bag mask ventilation. Yeah. It's difficulty in technique rather than true rigid chest.
Actual, yeah.
But when you do have a case of true rigid chest, the only thing you can use at that point is a paralytic. Right. And so if you still can't get your airway, at that point you don't have respiratory drive. So
should I take away from that you have a little bit higher understanding that it's exceedingly rare to begin with, but do you have a little higher instance of that in the neonatal population than we do the adult? I've heard of a few, in nearly 30 years, I've heard of a few isolated adult cases, right? And again, was it really a rigid chest, or was it something else? But
so in nearly 10 years as a neonatologist, I would say there are a handful of times when people have said there's rigid chest. Yeah. I'd say there are only very few that have truly been rigid chest.
Okay.
I don't think the incidence is higher. I think technique with bag mask ventilation is challenging sometimes. We were talking off camera about how, with our residents especially, my goal for them coming out of residency in terms of delivery room management is to be able to deliver good, effective bag mask ventilation. And if I have to make that my goal for residents coming out of residency, it's something that has a significant amount of technique to it.
Yeah.
And so I think most of the issues really are just technique based, but there's a few. There are a few, and the risk, be it theoretical or real, is considered enough that We don't want to put it out there for people to
the safer play.
Then go on and give a paralytic.
Yeah, the safer play is still the morphine.
The difficulty with morphine is obviously the time of onset is longer. The package insert and pharmacokinetics tend to say that the time of onset is longer than I think we see anecdotally using it, which is why we use it. I think, and you guys will probably know better than I do because you guys are the ones using it for intubation in the field, but I think our team would tell us that they have good success using the morphine for sedation, and while the babies are not necessarily completely out, they are sedated enough that it makes their airway easier.
Manageable. Mm-hmm. Yeah. Manageable and safe. That sounds like a good mix.
Yeah.
Mm-hmm. Yeah, no, it does.
Sounds like exactly what we want.
While we're talking about analgesics, do you guys use ketamine in the neonatal population at all? I mean, that's our. It's really becoming the go-to in the pre-hospital space. Just out of curiosity.
Swiss Army knife for everything.
It kind of is a Swiss Army knife for adults and
agitation.
Beginning to even see that even in the peds, but in the neonatal population, do you touch it at all?
Seldom.
Yeah.
I wouldn't say never, but seldom. Yeah. And it may come about more, honestly. In the seldom that we've used it in our more chronic premature infants. So the ones that are getting to be months old who've transferred from having that respiratory distress syndrome or that lung disease early in life into having bronchopulmonary dysplasia. And those ones that are very agitated, requiring very long-term ventilation, who at that point have been exposed to all kinds of sedatives, all kinds of analgesics and sedatives.
Yep.
And
just laughing at it.
Yeah, and at that point, and we have a palliative care team who's been super helpful in helping us with manage, especially agitation, but manage the long-term care of these symptoms of being chronically intubated or chronically ventilated. On occasion, we have used ketamine for that. It's definitely the exception still rather than the norm.
Than the rule, yeah.
One nice thing about ketamine, and again, I think you guys know this better than I do, is you use it sometimes for bronchospasm, right?
Yeah.
And
it's a bronchodilator.
Yeah.
Mm-hmm. And while the phenotype is slightly different, there is sometimes some bronchospasm in BPD, and so, or in bronchopulmonary dysplasia. And so sometimes it's nice as an additional therapy in these babies who are chronically agitated to add on for at least some theoretical respiratory benefit.
Sure.
In addition to the sedation.
So if we're talking about more the pediatric population, highly used in peds. We use it a lot for sedation in our peds, and then it's our go-to agent for intubations also, because if we're taking an airway in a kiddo, it's probably because of the airway also. Mm-hmm. So to get as much as you can out of it, that we would reach for ketamine to lead with for that, maybe 1% or whatever it is, just to get a little bit of extra effect from it.
Mm-hmm.
But as you said, like if you're coming out of the neonatal phase and bumping up against to the pediatric phase or the infant phase, probably more appropriate to use ketamine there than the neonatal phase.
Mm-hmm. And who knows, as it's around longer, it may seep into our neonatal population too.
But if you have a safe drug that's easy to use, it's well understood, like morphine or most of the opioids, why would you jump into another category that you don't really know? And as we know, it's hard to do these trials on pediatric patients, right? You can't do informed consent to do a trial on them, and they're special population, so experimenting on kids is not something we do in the United States.
Well, we do. There are studies going on all the time, especially in the NICUs. We're part of the Neonatal Research Network, which is it's from the NIH, but it's a collection of hospitals around the country where we all pool our data, just because it pretty much exclusively deals with the early preterm infant. But the numbers of early preterm infants are so small that you're never going to get enough patients from one center to do
studies.
To do really meaningful studies. So all of these centers get together and pool our data and get results. And there are studies going on all the time. So on our smallest, most vulnerable patients, it's the exact reason we do studies, right? There are some things that we just don't know what the right thing to do is, and we're not going to be able to find out what the right thing to do is without studying it. Yeah. And so we have, especially NRN studies going on all the time, helping us to kind of understand what's going to give us our best outcomes. And most of what we're looking at in neonatology is going to be your best neurodevelopmental outcomes, but looking at all kinds of outcomes.
that's the kind of outcomes that we want in emergency medicine. We talk all the time about, they might survive an incident, but what we want a neuro intact patient
Absolutely.
at the end, right?
Yeah.
That's the goal, is we want you, I want you at the same function that you were when the event started than afterwards. And if we're not reaching that 100% neuro outcome, then...
Not a win.
Correct.
Yeah, for the longest time, EMS was, I delivered him with a heartbeat. It's a win for us. It's like that. You have to recalibrate that's not necessarily a win. It's like they got to go home.
Yeah.
And it's
same or better, right?
Yes. And it's so interesting a topic, and I'm meandering off a bit here too, but
that's all we do here. So you're amongst friends.
Maureen Hack was one of the founders of neurodevelopmental outcomes research in neonatology, and she was with Rainbow for her whole career. And she did a study looking at, she did lots of neurodevelopmental outcome studies, obviously, but one of the things she did was survey the parents and kids themselves as they got to be older and looked at how they feel about their outcomes. So looking at former preterm babies who do have some neurodevelopmental impairment, so do have either some physical disabilities or some degree of cognitive impairment, and asking them how they feel about their lives. And what she found was both the patients and their families rate their quality of life higher than we would.
Most people, yeah.
It just gives some interesting perspective. So certainly 100% intact is always going to be the goal. But even when there is some neurodevelopmental impairment, the people who are living it feel much better about it than the studies show that we think we would.
Interesting.
That is, really is. Huh.
Might make us rethink how we think of like strokes and heart attacks.
Sure,
because that's two of the big things. Sepsis is another one, but rarely. I mean, I guess you could go to some type of organ failure, long-lasting, like kidney failure. You go from sepsis, but be curious to see what the patients think of their outcome. Like, if I had a stroke and I lost my whole left side, but maybe I only have a little bit residual on my left side, is that as good as a full recovery of having a...
When they're framing it up as what it could be.
Yeah, and we're looking for perfection.
Yeah, right.
And it's interesting. And in my population, I'm talking about people who don't know any different. This is the life they have always
lived, sure.
In the parents' case, this is the baby who they brought into this world, who they are taking home, who they have always known this way. And in the individual's case, this is the life they have always known.
Sure.
Yeah.
It would give some interesting perspective, though, on kind of conditions that end up with more chronic conditions over time, like strokes and heart attacks, and how do people really feel about their outcomes? Is an outcome where I have less stamina, but I still have some stamina better than...
Yeah. Because one of the things that I got... We talk about giving thrombolytics for strokes, and we're pigeonholed in this very tight time frame to figure out, do I diagnose a stroke, have imaging to show it's not a bleed, not a stroke, imaging to show it's not a bleed, and then decide, based upon the symptoms that I have, is this a stroke and would it benefit from thrombolytics? And then have the patient to consent to it. And I've gotten to these cases often where their NIH is really low, that's the scale we use for strokes, where it's not even recommended we give the thrombolytics, we offer it to the patients, and they're taking it, saying because their NIH is low, but they think that their facial droop is something that's debilitating and they just can't live with. And that's what I'm fighting against, is a facial droop. Would I personally take thrombolytics for a facial droop? Absolutely not. I will be happy if my facial droop will be okay. I can put eye drops in.
But you're very familiar with the risks of the thrombolytic.
Yep. Also true. And that's a conversation I have to have in a few minutes. And honestly, if we're talking about brain being seconds matter in that case, if I can get the thrombolytic a minute sooner I have to have a very complicated conversation about risks and benefits
in a very compressed time.
And in that same conversation, like, earn their trust that they're going to be able to, that they're making a somewhat informed decision.
You know, my mom, having suffered a severe stroke, she has deficits, obviously, and probably a year into that recovery, she was kind of like in the whole I hate life, why am I here? And now you talk to her and she'll tell you that, like, she's so happy she's here, and she takes every day as granted now, and it's like, that's cool. I see that she's progressed that way, but I would love to, the study would be awesome if that ever happened, to see, like, what do they think?
Yeah, I think one thing they have studied, though, I don't know with strokes, but definitely with heart attacks, is comorbid mental health disease, and how depression, regardless of how you feel about your heart attack necessarily, but people who have had heart attacks after their heart attacks tend to have depression.
Oh, yeah.
And treating the depression will help their feeling on their overall outcome.
She was on heavy depression meds at first, and now she's not on any, which is amazing to me. Like,
so the heart attacks that I've seen, the people that have had profound cardiac damage, to them it's almost like I was healthy one day, I had my heart attack, which we know is not really what happened medically, but
correct.
To them that's what happened. Like I was fine one day,
I was fine, then I wasn't,
and now all of a sudden I'm not, and now I have this month-long, if not years-long process to regain what I was back then. And I see
maybe even fractional perspective of what you had. Yeah.
The vast majority, and I'd be hard-pressed to even think of one person that came out on the other side in the short term. I'm taking at least a year afterwards to say, wow, I'm really glad that happened. They're all depressed afterwards. They're all hate that journey that they're on, because it's a lot of work to get back to where they were beforehand, going through that cardiac rehab.
Yeah.
So that was my case when I had my spontaneous pneumothorax. Yeah. When I came back to work, I didn't think I was going to be able to continue working, right? You don't realize, I had a bloodectomy and my whole back was open. I was like, it's like every minute of the day you're wondering, it's like, all right, when's it coming again? When's the next one, right?
Yeah.
And, here, 25 years later, it's out of my mind, right? But yeah, there was a year or two of significant depression immediately following that, because
it just goes to show you that the
was
true
fine, then I wasn't.
Mechanical problems that you might face can be fixed, but the mental is so much more half of that than we ever
should do a
believed.
podcast on this.
Well, the body and the mind are so connected.
Yeah.
Yeah, and you're totally out of my field, but I'm enjoying the conversation anyway.
Yeah.
Several years back, I was camping, and like most times I'm camping, I was drinking, and it was hot, and I was losing a lot of liquids and fluids. And
I don't know where this is going.
I started having PVCs like crazy, right? So being in the medical field, I knew that we had monitors at UH, so I went and ran my own EKG, and I was having, trigeminy PVCs consistently. And, I'm not having a heart attack, so I went back home. I tried to sleep, couldn't sleep, ended up, I need to go to the doctor. Well, my electrolytes were so off, and my potassium was so shot. And it's like the anxiety was making it worse. So the fact that your mind is so connected to your body, like you said, like.
Well, you also made the mistake that medical professionals make so much. The way medical professionals die at home is.
We are our worst patients.
This will be better if I just sleep it off.
Yep. I tried that. I woke me up, thank God.
I mean, truly, thank God.
Cass is like, go take a bath. I was like, no.
That's the way that medical professionals really do damage to themselves.
I believe that. And that really woke my eyes up to it, though, that, like, this is how people die. And I'm like, I went home. Like, why wouldn't I have gone to the hospital?
There's so many doctors who've thought, my chest hurts is probably indigestion. I'll take a nap.
But you're so dead on. I had a guy on shift not that long ago that was having chest pain, so hooked him up to the monitor. He was running SVT, and he's like, huh. So he got ablazed after months later, but still, it's like, he was just going to go home. He's like, I just didn't feel good. So let's look you on the monitor.
We had one of our own 2 months ago. Didn't feel good on shift, and he was on a STEMI.
Yeah.
So.
Oh, yeah. Yeah, absolutely. My personal observation with kids, not so much, I don't have a ton experience with the neonate, is kids, like specifically with benzodiazepines and kids with narcotics that I've given over the years, they seem to like burn it off really quick, right? It's like my duration of action seems to be way shorter on kids. Is that the same for neonates, or is it converse, or how does it play out, or is it completely dependent upon?
It's completely dependent upon each individual's physiology.
Yeah, all right. So we shouldn't have that same mental model per se of, I might have to redose. It might slog them for a while, or it might. Okay.
Yeah, some babies will burn right through it, and we'll have babies who we give intubation meds to who are waking up during our intubation experience. And we have babies who we give intubation meds to who still have no spontaneous breaths on the ventilator the next morning.
3 days later, still trying to,
Maybe not 3 days, I hope. Yeah. Part of that has to do with a lot of the drugs we use are renally metabolized and renally excreted. The preemie kidney have different energy than than the kidney. And when you take into babies can also have injury or AKI. That can also affect the way they metabolize and excrete.
Do you guys try to avoid hepatic drugs in your neonates?
Not necessarily.
Okay.
No.
Because I guess that's a
question. Yeah.
Well, I'm thinking that most of our drugs we do, we don't use our hepatic drugs in our kiddos for the most part. Propofol, we do, but like we don't use propofol for sedation in pediatric patients because they will burn right through it.
Yeah, we don't use propofol either.
Correct.
But
I'll just make them. We'll just have a bunch of triglycerides floating around in their bloodstream.
Well, we have that anyway because we do use intravenous lipids.
Yeah.
But quite a bit. I do think that most, if not all, of the sedatives we use are.
Mainly.
I can't think of any. I can't think of any exceptions at the moment, but I think most of them are renally metabolized and excreted. When I said we don't necessarily avoid hepatic drugs, I was thinking more things that cause hepatotoxicity or. Of course, we try to avoid hepatotoxicity, but sometimes you just need what you need.
Correct.
Yeah.